If I could have everyone's attention, I think we're going to go ahead and get started. Good afternoon. I'm Caroline Young, President of the Nashville Healthcare Council. It is my distinct pleasure to welcome this esteemed group of speakers here today. It is an honor that the Bipartisan Policy Center has selected Nashville as a location for this important discussion on healthcare coverage and quality. It's an honor, but I must also add that it's very appropriate, as Nashville is this nation's healthcare industry capital. No other community has the concentration of healthcare expertise that is found here in Nashville. Nashville is home to 300 diverse healthcare companies. 15 of these are publicly traded on Wall Street. The industry cluster here accounts for $45 billion in annual revenue and employs more than 300,000 around the globe. For the past 30 years, this unparalleled industry cluster has been fostered by entrepreneurial leaders who have created innovative models of care delivery and clinical practice efficiencies, all while maintaining a constant focus on the patient. Without a doubt, the decisions made by the executive teams running these companies here in Nashville impact top quality health care on a daily basis around the country. Senator Baker, Mr. Jennings, Mr. McClellan, and other distinguished guests, I invite you to tap this expertise. Please let Nashville's healthcare community be a resource to you during these discussions of healthcare policy reform. We look forward to working with you. Thank you.
Thank you, Caroline. Welcome. I'm Matt Kennedy with the Bipartisan Policy Center. I'm the Director of Health Policy, and I'm just going to briefly give you a bit of an intro to the BPC, as we call it. We were founded in March of 2007. We're a relatively young organization in Washington, D.C. by Senator Baker and his colleagues, Senator Tom Daschle from South Dakota, Senator Bob Dole from Kansas, and Senator George Mitchell from Maine, all former Senate Majority leaders. Our mission is to really to focus on bipartisan consensus on the many policy issues facing our country. And we do that by bringing together experts from both sides of the aisle, and then again by bringing together stakeholders from different sides of issues to really work through and talk through their disagreements and find areas of consensus and develop policy recommendations that we then will work within the political system, will work with Congress and the administration to try to enact. So we're a little bit more than just a regular think tank. We also try to engage Congress and the administration and actually see the recommendations that we develop implemented. And so I wanted to just give you a brief highlight of the many projects that we have going on at the BPC. As you all know, we're here to talk about the Leaders Project, which we'll get to in a minute. Our first main project is what we call the National Commission on Energy Policy. It was really the organization that served as the precursor to the Bipartisan Policy Center. It was founded in 2002. It was a group of stakeholders who came together to develop energy policy for the next 20 to 25 years. And they had such a success at really trying to bring together diverse interests that they thought that they should expand upon what they did and try to branch out into other policy areas. And so that led to the formation of the BPC. We also have a project on transportation policy that is led by former Senator Slade Gorton from Washington, former Congressman Sherry Boehlert and Martin Sabo, and Dennis Archer, who is the former mayor of Detroit, Michigan. Their mission is to really look at the current transportation funding mechanism in the country, look at ways that we can improve upon it, and plan for transportation policies that meet our needs for the 21st century. We also have a national security initiative that recently released a report on preventing a nuclear Iran. This project was led by Senator Dan Coates and Senator Chuck Robb. They essentially put together a decision tree of what the new administration, President-elect Obama, and Congress could do to prevent Iran from developing nuclear weapons. We got quite a positive response to the report, and they're looking to do some similar work in the months ahead on stabilizing fragile states and looking to stabilize democracies across the world. So we have some really great policy work going on at the BPC, but as I said, we also have a political edge to us as well. Our belief is that the party system is really the backbone of the country. It provides stability in Congress. It provides us with choices of candidates during the election process, but we also believe that there's a time when you need to put aside strong political differences when you're making policy and really trying to sort through differences and come up to solutions to problems that average Americans face. So we do have a political side to us. We do advocacy work on the Hill. We had events at the political conventions this year. We'll probably do some events next year with the inauguration. So we're very much kind of geared towards both bringing a spirit of bipartisanship to both policymaking and the political process. So without further ado, I want to introduce Senator Howard Baker, who I'm sure, and he's no stranger to any of y'all, and I say y'all because I am from Texas originally, and it's, I was telling some of my colleagues that it's good to be back in a state where I can use expressions like folks and all y'all, and I don't get looked at really strangely. So I'm happy to be back in Tennessee, and as I said, Senator Baker is not a stranger to any of you. He served 3 terms on behalf of the state of Tennessee, 2 terms as minority leader, 2 terms as majority leader, was President Reagan's chief of staff, and also served as ambassador to Japan. We feel that he is the exact type of statesman that we need to lead us through the healthcare reform process as we look ahead in the next coming years, and we are very grateful that he's agreed to be here today and agreed to take on this issue. So, Senator Baker, welcome.
Thank you very much, ladies and gentlemen. It's a pleasure to be here. It's a pleasure to have you here. It's an important time, important issue, and we have an important address to these issues. Well, first of all, I guess I should congratulate all of you for being in Nashville. Nashville is a great city, the capital city of our state. It is also the location of a vigorous, vibrant healthcare industry. I'm pleased to be hosting this meeting in support of the Bipartisan Policy Center's project. Last April, as I said earlier, Tom Daschle, Bob Dole, George Mitchell, and I, who are all former majority leaders, decided to form this effort to explore the possibility of coming together on major issues that have troubled, in some cases, and challenged our country over time. My friends, let me say this. The fact that it is denominated as a leaders' project in no way means that it is the uniform view of the 4 leaders. It is rather our stated objective to see where the common ground is, how we can put together positions that will be attractive, not only to the members of Congress and the administration, but to the country as well. It is often said, I think, that every great issue has its time. I can remember when environmental issues first had their time. And for years, there was a great debate in the Congress about the passage of clean air legislation or clean water legislation. And I remember as well that finally we came together and passed a body of laws that became the cornerstone of the environmental legislation of this country. I remember as well when we were dealing with the terrible issues of civil rights. I can barely remember, I hasten to say, the early days of that effort, but I do remember the latter efforts, including the passage of the Voting Rights Act and others. That, too, was a great issue that confronted our country through a great war between the states. But gradually we came together. It was almost an unspoken determination to address this issue, and we did, and did so, I think, successfully. My friends, it is in the nature of democracy, in my view, that these things occur. It is not to be explained by me or anyone else why it occurs, but it's one of the crowning jewels of our system, I think, that we do not try to decide issues. We cannot decide issues suddenly and overnight, in most cases, but rather we see, sense, and understand the will of the people over a period of time. And the issues and challenges, as well as the answers to these great problems, emerge and become statute law. And so it is, my friends, with the issue of health care, in my view. First of all, I would say that we are not attempting, I'm not attempting, I don't believe my colleagues are attempting, to find a consensus view that embraces everyone's point of view and forces a view that one particular position is necessarily the only position. I would point out, though, that bipartisanism is much more than that. I would also point out that the earliest days of the Republic, our founding fathers thought that factionalism, as they called it, factions, would be the undoing of our effort to succeed. And I'm happy to say in that case they were wrong. But you see, that too has become uniquely American. Almost without structure, we identify these issues, we address them, usually over a period of time, and propound a solution. Perhaps it's not a total solution, perhaps it's not a permanent solution, but it's a forward-looking solution. My friends, I'm not trying, as my part of this effort, to have a Republican consensus or a Democratic consensus. I am rather here to try to point out the urgency of this challenge and to point out as well that conscientious men and women in government and outside government have worthwhile views that must be taken account of without the friction, without the preconceived notions, without the positions previously taken on these issues by them or by their party. That is bipartisanism, as I understand it. And it has served us well. Friends, I believe it will again. And I urge you to think in those terms. We're not trying to force a consensus view or political or partisan view. We're rather trying to address the issue in its most fundamental form, to compare notes, to examine the alternatives, the experiences, and to come up with recommendations that we can make to Congress and to the administration, and most important to the American people, on how we can do this. In a word, what we're trying to do is to elaborate and extend the blessings of good health care to more and more people, to do it more efficiently, at less cost, and to do it without destroying the best health care system in the world. That is it's not an easy job, but I submit to you, my friends, it is not an impossible job. So I hope in this effort today, and others like it, we will take it on that basis. We're not trying to be critical of the past. We're not propounding a particular point of view. We are trying to marshal our resources, our attitudes, and to present it to the Congress, to the country, as a possibility of the next effort in the improvement of health care reform. Friends, there are people here at these tables, in the audience and elsewhere, who are far more experts than I on this subject. But I depend on you, all of you, to share your views without prejudice, without partisanship, without preconceived notions, to contribute to our continuing effort to make the best healthcare system in the world even better. Now, friends, I could go on. There's some in this audience who know me well. I'm afraid I will. But I shall stop here and say, I thank you for my part for your participation. I'm glad you're here. I look forward to your contribution. Thank you very much.
Well, what an honor it is to be here with Senator Baker. I'm Chris Jennings, and Mark McClellan and I serve as the co-staff directors of the Bipartisan Center. It's also quite an honor to be joined up in front with Sheila Burke, who was Senator Dole's former chief of staff and a health policy expert and just a real asset in every way to us throughout this process. And I'm here first and foremost to welcome you, but secondly, to lay the predicate for how we're going to do this. But before I do all that, I'm going to I was talking to Senator Baker a little bit before this forum about the reasons why, as he put it so cogently, the time may be right for a broader health reform discussion and where exactly the Bipartisan Policy Center may fit within it. And I'm going to ask Mark then to come up to talk a little bit about our approach that we're taking, and then we'll go through the process of today's forum. First, and by the way, I come at this from serving in the White House for 8 years, but also having the honor to serve in the Senate with Sheila and Senator Baker for 10 years for 3 senators, Senator Glenn, Melcher, and Pryor. And I do agree with the senator that the time may well be right. I've been doing this for 25 years, and there are those moments in time when you just get a sense that things are possible. And despite all the reasons why it would be hard and will be hard, and we have to acknowledge that up front, we have deficits, we have competing priorities, we have different ideological approaches. You could list a whole lot of things. But the fact remains that usually this country responds substantially and significantly when there is a crisis. Not when there's no crisis, there are no problems, or we might be able to come together, but indeed when there is a crisis. And you can look back to the history of this country and look at the Great Depression and the Social Security program. But what's quite intriguing now is that no longer is this a discussion between healthcare policy people and economists. The economists now believe that you cannot extricate healthcare from the economy any longer. Indeed, they came to that conclusion a little bit later than most people have. But if you look at some recent exit polling of the election that just took place and looked at the question, what is your greatest economic concern? And the questions were aligned, so it's either gas prices, your job loss, your 401k, healthcare, et cetera. The first top answer was healthcare. So the idea that you can talk about the economy without talking about healthcare is just not true. And in fact, the economists, whether it's Ben Bernanke or former Secretary Summers, or the Congressional Budget Office, now soon to become the Office of Management Budget Director Peter Orszag, or the former CEA Director Joe Stiglitz, all have concluded the same thing. And shockingly, not, the business community is ahead of them. Large and small, manufacturing and retail, are asking everyone to come together and to engage in this debate. And in a way, they are frequently in Washington the tiebreaker, and they're at the table. We have a whole quality value debate that never existed now, where the experts in this room can talk to us about how we can improve our return on investment. And indeed, if we don't, we won't be able to afford our current liabilities. Peter Orszag, the CBO director, frequently talks about how fully 1/3 of the costs that we spend on healthcare are for outcomes that are for services that do not improve medical outcomes. 1/3. 1/3 of $2.1 trillion a year is $700 billion a year. People get this. And lastly, I'll conclude with this, that the stakeholders, whether they be consumer businesses or plans or providers or manufacturers, are all at the table asking for this discussion to take place and to have real progress. Which brings us back to the Bipartisan Policy Center. and the leadership that Senator Baker, Senator Dole, Senator Mitchell, and Senator Daschle have well illustrated. Members, what's so interesting to look at these leaders is to watch how members of Congress today's members of Congress, go to them to say, give us some guidance. Don't give us the final prescription, but give us guidance and some framework for us to proceed, which is exactly why we're here today. I'm often reminded when I conclude my presentations about something that Winston Churchill always said about Americans. He said that they will always get it right, but it's only after they've exhausted every option first. And I think we're pretty close. To that end, I'm going to ask my colleague Mark McClellan to come up, fill in a little bit of the details about what we're doing from the Bipartisan Policy Center, and then he and I are going to split duties about how we're going to run the process today on behalf of Senator Baker, and certainly asking the Senator and Sheila to weigh in throughout the process. Thank you very much.
Thanks, Chris, and thanks especially to all of you who are here today. It's terrific for me to be back in Nashville. I had a chance to work with many of you as I look around the room when I was in government at FDA and CMS and implementing some major reforms at that time. And what was clear then is what's still clear now, that this is the crossroads for healthcare and healthcare innovation in this country. And that's not just innovation in medical technologies, but innovations in the way that we deliver care. So it's a real privilege to be back here, and I can't think of a more appropriate place, a more appropriate set of experts for working with to move forward on the Leaders Project on American healthcare and healthcare reform. It's also a special privilege, as Chris said, to be working with someone like Senator Baker. Now, I obviously knew Senator Baker's work very well over the years for finding a bipartisan way forward on such challenging issues as the environment and, in previous cases, on many important types of health care legislation. I should also add, Senator Baker, that I grew up in a household where my mother was very much involved in politics down in Texas, and her role model was Senator Kassebaum. So I heard about her all the time as well. It's a terrific, I'm sure you did, terrific contributions. And it's also a privilege to be working with Sheila Burke. As Chris mentioned, she has a long history in working with the leaders on healthcare reform issues from her leadership on the staff of the Senate Finance Committee on health issues. Sheila is now, among many other things, on the faculty of the Institute of Politics at the Kennedy School of Government, and I think Sheila has to head straight from here back to Boston to do an orientation for many of the new members of Congress who are very interested in healthcare reform issues this time around for the reasons that Chris mentioned. So we've got the makings of what will hopefully be a very informative and stimulating discussion today about how to move forward on healthcare reform. And I'd just like to give you a couple of minutes of framework for where we are now with the Bipartisan Policy Center project. We've identified 4 major pillars for healthcare reform. These are reflected in the discussion that we're going to have today and also reflected in some of the prior work to get to this point in the BPC project. First, as Chris mentioned, is a new emphasis on value in healthcare reform, on getting to better quality and lower costs through making an emphasis on reforming health care and supporting the efforts of healthcare providers, patients, everyone involved in delivering care, making that front and center in the healthcare reform process. I mean, it's always important to remember is that healthcare reform really doesn't happen in Washington. It happens all around the country, including places like this one, as we'll hear about shortly. There are a lot of really good ideas that people are implementing that are leading to better health at a lower cost, that are amounting to better ways to deliver care, and often our policies don't support it. We want to have policy reforms that help healthcare providers and everyone involved in the healthcare system get care right, get the right treatment to the right patient, the right time. Too often we're failing in doing that today. We have a paper coming out from the BPC very soon on this broad topic, which will cover such aspects as the important role of health information technology as a supporting tool, the important role of better evidence on what works, comparative effectiveness of treatments, but also medical practices and our policies that influence medical practices, as well as reforms in payments and benefits. Again, it's not just a matter of putting more money into our current healthcare system to try to make healthcare more affordable. That's probably not going to work, but spending that money better, finding better ways to support what it is that healthcare providers can do and patients can do to get better care at a lower cost. So we'll keep coming back to that topic today. A second major pillar is obviously affordable coverage. This is where a lot of healthcare reform discussions start. It's a key part of what we are working on as well. The BPC released a paper on this topic several months ago, which is available on the website, that describes some of the options for getting to more affordable health care coverage. And just want to emphasize that we're not talking here about a wholesale replacement of programs that are working now, including employer-provided coverage and the Medicare program and the Medicaid program, but rather focusing in first on the areas and the individuals who do not get good coverage options, or not lucky enough to be working for an employer or eligible for an existing public program where good coverage is available. So we will be presenting some options and moving to some specific proposals on how to do that, how to make sure that all Americans have access to affordable coverage. A third key pillar is to get to sustainable financing. This is something I think we can only do by putting the first two pillars together, but also by looking, frankly, at some significant reforms in the way healthcare is financed. And the BPC has also released a paper on this topic that covered such issues as player pay ideas, and also spent a lot of time on tax reform issues, something that came up and has been the basis, coming up in the campaign, has been a basis for bipartisan proposals in the U.S. Senate to find more affordable ways to get coverage available at a lower and more sustainable cost to all Americans. And finally, a fourth pillar is individual responsibility and support. Individuals have a very important set of responsibilities in healthcare reform, including in such areas as making sure or taking steps towards getting coverage that can help prevent their costs from spilling over and adding to the costs of others in the healthcare system, and by taking some steps with their own behaviors towards healthier practices that can help us keep healthcare costs down and help everyone lead better lives. Unfortunately, we don't do a very good job of supporting these kinds of steps in our current healthcare system. So along with an emphasis on individual responsibility must be an emphasis on finding ways to help people find coverage that meets their needs at a low cost, helping people get the information they need to make informed decisions about their coverage and about the healthcare practices and services that they're using. So all of these are part of the overall framework for healthcare reform that the Bipartisan Policy Center will be proposing soon as we head into this big healthcare reform debate next year. And I just want to second what you've heard from the other speakers today, which is that there is a window of opportunity now. It's a window of opportunity that's open because of the severe challenges and public concerns about the cost of health care, the quality of care, the affordability of health care coverage in this country. But it's also a window that's open because of the work that many of you all are doing to show that we can do better. There are better ways to deliver care. There are better ways to provide coverage. And with the right health care policy reforms, we can make some real progress in making affordable, innovative care, as Senator Baker said, care that continues to lead the world in its technical capabilities, in its innovation, make that available to all Americans, and do it in a way that's sustainable for our economy. So it's a tall set of orders that we want to deal with today, and we very much looking forward to hearing the best ideas from all of you who are assembled here, some discussion around the best ways to move forward as we meet this very important set of challenges. And with that, I'd like to turn this discussion back over to Chris. Chris, I don't think you need to get up as we get started on our discussion. Thank you all very much.
Okay, this is the fun administrative part of this process, and then we'll go quickly to the presentation. We are just so pleased to be here with this wonderful group of speakers and discussants. Seated around this table are the leaders and policymakers driving the healthcare reform forward at both the state and national level. Tennessee is indeed a capital of health reform, and it's an honor to be here again. I was here just a month ago to learn that very fact. You all have unique insights on how increased quality of care can be combined with efforts to ensure that all Americans have health care coverage, and how taken together that can greatly improve the value that we have in the nation's healthcare system, but much more importantly, in improving the nation's health. Before we get started, I'd like to provide a brief overview of today's event. The proceedings will be divided up into two sections, one focusing on each of the forum's topics, the first one being empowering health professionals to provide efficient quality care. And I'll get to the second, but that will be focused on coverage. Each of the designated speakers will have 5 to 7 minutes to make their prepared remarks. And unfortunately, I have to be the one to say, stop talking if you don't do that, because Senator Baker won't do that. Mark, you may have to do that occasionally. Once that you have finished, there will be a time for questions and additional discussions. At that point, we'll open things up to the full group around the table. We found this to be very, very fruitful in our previous forums, where we actually have some give and take discussions to improve the dialogue. And one thing that I would ask you is that before you talk, you press this button, because we will not be able to hear you if you do not. Once we finish the first topic, we'll take a very short break, and then we'll reconvene and move through the second discussion topic. So with that, I'm going to turn it back to my friend, my colleague, and my overqualified co-staff director, Mark McClellan.
Thanks, Chris. For our first topic, our first panel, we're going to talk about the important role that providers play in helping us get to better value in the healthcare system. And what I'd really like to emphasize and hope we can bring out in the discussion is, how do we do it? How can we get to better care at a lower cost? As Chris said, it's something that you hear a lot about these days in the policy debates in Washington, that gosh, if we're really spending so much more money than we need to spend to deliver health care effectively, how is it that these gaps can persist for so long? Why isn't it the case that the good ideas that many of you all are leading haven't become more widespread in our healthcare system? And how can we build that into healthcare reform efforts? And I can't think of a better group of people to lead the discussion of this topic than the ones we've got assembled this afternoon. Let me start with, on my right, with Jim King. Dr. King is a family practitioner and medical director from is it Selmet? Haven't had a chance to visit there yet, but hopefully soon. That's in the western part of the state. Thank you very much for making it here today. Dr. King is also the chairman of the board of the American Academy of Family Physicians, and is in that role playing some very important roles in helping to develop the AFP proposals for healthcare reforms, including proposals that really put the emphasis on getting more value and improving quality of care. We've also got 3 distinguished experts from Vanderbilt University, and it's easy to see why Vanderbilt's such a key source of ideas for healthcare reform in the United States and here in Tennessee. And that includes Colleen Conway Welch, Dr. Peter Burhouse, and Dr. Harry Jacobson. Colleen and Peter and I have had the opportunity to work together on many issues, particularly relating to the role of nursing in improving health care. Colleen and Peter have both highlighted some very important opportunities for improving care and delivering care more effectively through greater use of nurse practitioners and other nursing professionals in delivering health care. Harry Jacobson is the Vice Chancellor for Health Affairs at Vanderbilt, and he's the CEO of the Medical Center, where he has been very much involved in leading the implementation of reforms, not only in health care through the Vanderbilt system, but also in medical education. So it's a pleasure to have you here with us as well. And then next is my good friend, Dr. Jonathan Perlin, who is going to talk about some of his work related to health information technology as a tool for improving quality and safety. Before his work now at the Healthcare Corporation of America at HCA, Dr. Dr. Perlin was the undersecretary at the VA overseeing all of their work, overseeing the entire VA healthcare system, where he was instrumental in implementing health IT systems effectively to reliably and consistently improve care and its efficiency. And Dr. Perlin has also been involved more recently in the process for the American Health Information Community, a broad public-private activity to continue in a sustainable way to support the effective adoption of health IT throughout our healthcare system. And finally, and certainly not least on this panel, is Nancy Annis, who's from St. Thomas Healthcare Services. She works very closely with their network of outpatient clinics and can talk about some of the steps that St. Thomas is taking to ensure that individuals in rural communities, individuals who otherwise might have some of the biggest challenges in access to care, do in fact have consistent access to high quality care. And just before we get started, it's that final reminder that we want to have a very robust discussion from this distinguished group, and so I'd like to ask you to keep your initial remarks to 5 minutes. And Dr. King, if you don't mind, we could start with you.
Be glad to. It is an honor to be here, and I am the board chair of the American Academy of Family Physicians, which represents over 93,000 family doctors across this country, located in every county. Family physicians do an excellent job of taking care of our patients. We are well trained to take care of the entire patient, physical, social, emotional, and even spiritual. We supply patient care that is comprehensive and with continuity. The question is, then why does the United States finish 19th out of 19 industrialized countries in quality indicators? What do these countries have that we don't? IBM asked the same question about their employees. IBM has many employees both in the United States and in those other 18 countries. IBM's employees outside the United States receive higher quality health care, were more satisfied with their health care, and IBM had to pay less for it. What IBM found was that in those countries, they all had one thing in common. They were all primary care-based systems. The United States has well-trained physicians who care about providing the best care for their patients. We have excellent hospitals such as Vanderbilt here in Nashville that seems to have the most up-to-date technology. So why are we last? Our system is fragmented and episodic. You have to have an illness before the system takes care of you. We neglect preventive care and the significant disease management in a way that makes sense. We have patients seeing the wrong physicians in the wrong places for the wrong reasons, and we have a perverse payment system that rewards this behavior for both patients and physicians. The 4 primary care organizations, the American Academy of Family Physicians, the American College of Physicians, the American Academy of Pediatrics, and the American Osteopathic Physician Academy, which represents over 333,000 physicians, have all joined together to develop the principles of the patient-centered medical home. The American Medical Association has now endorsed these principles just last month at their interim meeting. The Patient-Centered Primary Care Collaborative, which makes up over 150 different groups, which includes major employers, labor unions, patient advocacy groups, these medical organizations, and yes, the 7 major health insurance companies have signed on to these principles. The principles are simple: patients first, team care, continuous care, and community care. Practices will use technologies such as electronic health records, disease registries, e-prescribing, and open access scheduling to improve the satisfaction and quality of care for our patients. I live in Selmer, Tennessee, a town of just over 7,000 citizens, and we do what we can do in that same small town, we can do in this large city of Nashville. But some very important things have to happen. We, the physicians, have to change the way we practice medicine. We must think about our communities in groups of people instead of only the individual patient. We must use evidence-based medicine, protocols, flow sheets, and the internet. These changes will not be easy and will definitely be expensive for the practices now that have a very thin bottom line. Employers and the other buyers of health care, such as the government, must change the way they pay for health care, especially primary care. The AAFP is talking about a blended payment system which continues to pay for fee-for-service, but added to this is a management fee and pay for performance which truly improves quality. The Patient-Centered Primary Care Collaborative agrees with these principles of payment for these added services. Primary care is undervalued and definitely underpaid. Everyone from government, employer community, hospitals, subspecialists, insurance companies, and even our patients agree. We have many reasons why young people are not choosing to go into primary care, but a major one is they feel that they are undervalued for the time and work that they have to do to become a doctor. So why don't we just pay more for primary care or family doctors? I'd vote for that, but I don't think the rest of you will. And it's just because everybody's saying the same thing. Don't take it out of my pot. The buyers of health care say that they already pay too much. I have to agree, we spend $2.3 trillion a year. General Motors spends more on health care than steel. Health insurance premiums fall somewhere between 25 and 50% of people's incomes, and at the same time, they're paying more out of pocket. The non-primary care providers of health care say that's fine to increase primary care pay, but just make sure it doesn't come out of my pocket. I can't afford it either. So what do we need to do? We need to make sure that our patients are seeing the right physician in the right place for the right reason and get the right care. The patient-centered medical home is the first step we need to take to make sure this happens. I truly believe that we have an opportunity to make a significant change that will move the United States back to the top of the charts where we belong. It is exciting to see all the stakeholders in the healthcare system at the table talking about change. I look forward to the question and answer session and the rest of the afternoon, and hopefully as we work together to fix this broken healthcare system. Thank you.
Good afternoon. Dr. Burhouse is going to talk about the RN shortage in general, and I'm going to focus on the advanced practice nurse issues. I have a few copies of my presentation that will be available, but after this afternoon, this presentation and slides will be on my website under Dean's Speeches if anyone would like to review it or, frankly, use it. We know that. Thank you. Next slide. We know that people are living longer. And next slide. We know that the number of primary care residents in primary care programs is basically flat. Many primary care physicians are voting with their feet and moving on to specialty practices. And as Dr. King emphasized, a lot of that is because of the salary levels, as well as the debt load that they carry from medical school. Next slide. Our healthcare system is facing a perfect storm: an aging population, a shortage in primary care physicians, a shortage of nurses, and a growth in the uninsured and underinsured. Next slide. And our system is full of handovers. And what do I mean by that? Well, lots of opportunities for mistakes. You are a patient admitted to a unit, you have other people that deal with your pre-ops, you then go to surgery, you then go to a recovery room, perhaps an ICU, a step-down unit, then to a regular unit in the hospital, then home care, palliative care if you're not doing too well, and perhaps hospice care. Every single one of those handoffs is a unique opportunity for a huge problem in terms of quality and safety of care. Next slide, this slide. So, I'd like to talk a little bit about advanced practice nurses and what they can do. They are masters in doctorally prepared nurses. They give advanced nursing care. They have courses in advanced pharmacology, advanced pathophysiology, research and evaluation, critical thinking, project evaluation, just to mention a few. Next slide. There are 4 types of advanced practice nurses: nurse practitioners, nurse midwives, nurse anesthetists, and clinical nurse specialists. Next slide. This slide is a bit complicated, but it shows that on the role of the advanced practice nurse in population health management that can focus on both minimizing risk as well as disease management. Next slide. So why advanced practice nurses? Why should we invest in them? They're experts in population health management. They can legally diagnose and treat a vast variety of health problems. They can write prescriptions. They are recognized as billable. They are much less expensive to educate than physicians. They can be produced more quickly, a minimum of 3 or 4 semesters after basic baccalaureate nursing preparation of 8 semesters. Next slide, please. How many are there, and why aren't we better using them? Well, there are over 250,000, but only about half of them are practicing as billing nurse practitioner providers because they are not allowed to practice in their legal full scope of practice in their states. Next slide. And why can't they practice? Frequently, the boards of medical examiners in many states, except frontier states, such as Wyoming, restrict nurse practitioner scope due to fear of competition and perceived financial threat. Now, I will say that this was quite pervasive in years gone by. However, many physicians now are recognizing that bringing more nurse practitioners into their practice allows them to see more patients, and that drives volume. However, that does get into the perverse financial incentives that we address. I would like to say that nurse practitioners working with colleagues, physician colleagues, are better able to address the quality and safety issues that come along. Next slide. Dr. Burhouse will be talking about this, but I just wanted to add that 53% of nurse faculty are 58 or older and plan to retire in the next 10 years. And there is little consensus on the numbers of APNs we need because our data is so marginal and so fractured. Next slide. The number of lawsuits filed against advanced practice nurses is almost negligible. Next slide. So what to do? I'd like to make 11 points. We need better statistics. We need to regionalize our educational programs. We should not be all things to all people in every school. We need federal preemption so that the standard of practice across the states is similar. Nurse practitioners can give 50 to 90% of the care now given by family practice docs, and general OBGYNs, and general pediatricians, depending on the expertise and experience of the practitioner and the acuity of the patient. So allow primary care to be done by nurse practitioners, encourage physicians to considering primary care to go into specialties. Next slide. Invest in schools of nursing with distance learning capacity. Support technology advances. Today's nursing shortage assumes work will be done in 10 years the same way it is now. That is ridiculous. The work environment is going to change dramatically. Explore why nurses are still hunters and gatherers. 30 to 40% of what a nurse does today is still looking for things, finding things, putting things back. Why can we track a FedEx package to China and back and we lose a patient on the way to X-ray? Next slide. Expand federal programs that encourage nurses to become faculty with enticements such as loan forgiveness, and realize that NIH research funding, when that takes a bath, NIH funding for the National Institute of Nursing Research hits a tsunami. Yet these are the future doctorally prepared faculty in our schools. Next slide. Fund scholarships for full-time and half-time nursing students. There's almost no money available for part-time students. And do modest stipends with required payback in underserved areas. And increase funding for the National Health Service Corps. There's a recent publication, next slide, which has 6 recommendations. And the number 5 reads, immediately revamp regulatory mechanisms to allow nurse practitioners to practice independently to meet primary care needs, at least in regions with designated medical shortage areas. Next slide. Imagine a country without enough nurses. Imagine you're in a hospital or nursing home without enough nurses. Remember, Marcus Welby was a nurse practitioner. He just didn't know it. Next slide, please. Thank you.
Peter?
Do you want to, it's up to you.
If you don't mind.
Oh, that's fine. Okay.
Thanks. Well, thank you very much, Senator Baker, Chris, Mark, and Sheila, for the opportunity to be here. And what I'd like to do, if you'll go to the next slide, is just make 3 points. First of all, we have a current situation in the nurse labor markets that is a little bit mischievous and is likely to fool us and lull us into problems in the long run. In the long run, we're looking at shortages that could develop of such a size that they will thwart any efforts for health reform. They will potentially lose American jobs, and finally, they will harm the quality and safety of health care. The good news is that future can be avoided with, I think, timely bipartisan private and public sector policy. Next, Matt. To just make this first point about what is happening in the current nursing workforce, the current shortage, which began 10 years ago in 1998, is ending. And it is ending thanks to, if you will, the downturn in the economy. What's happening is that more and more spouses of nurses, and 70% of nurses are married. So as their spouses begin to lose their jobs or worry about this, puts a great pressure on the nurse to be working. She or he may be the only income earner in a family. So many RNs are returning to the labor market today, and we've seen this sort of activity in previous economic recessions in the past. This next slide just shows you in more current data. In 2002 and 2003, as the unemployment rates increased following the recession in late 2001, you see tremendous growth in hospital RN employment. These are record growth in a yearly change in employment. As you travel down to 2007, now in the final quarter of 2007, unemployment rates are beginning to tick up. The housing market, the subprime crisis are all beginning to happen, worrying households of nurses, stimulating again a near record increase in the employment of RNs. Next, Matt. So as we look to 2009, there's some caution. We're going to hear about nurses, more nurses working, new graduates saying, where's that job? I can't find that job. More people wanting to become nurses as they look for recession-proof or recession-resistant sort of occupations, and hospitals throughout the country saying, the shortage is finally coming to an end. How grateful we can be, and move on to other things. And I want to just issue a little bit of a caution, because what's really going on is an underlying trend of a rapidly aging workforce, and it will have implications downstream, but we're already beginning to see that now. And we'll soon, well, in the next decade, begin to see the size of our workforce leveling off, plateauing in size. You can see that these trends have already begun. This shows data again over the past 6 years. And if you look to the right column in this slide, all the action is with the aging RN, those RNs that are well into their 50s. And so as our team plots these out and moving forward, if you'll go ahead again, Matt, we see the average age of the workforce just increasing steadily along up until over 44 and then leveling off. Here's the supply of nurses. These are real data we've been tracking. The projections are in the pink. They rise slowly, level off, and by the year 2025, we project roughly 30 or 40,000 more RNs then as we have today. But meanwhile, here's the demand for RNs, rising 2 to 3% midway through the decade, and with shortages by the year 2020 of what we estimate at 285,000. That would be about 3 times the size of any shortage that we've ever had since the days of Medicare and Medicaid. Those shortages then are projected to rise to 500,000 by the year 2025. Shortages of that size would be overwhelming to the healthcare system. Yet, as Dean Conway-Welch mentioned, unbelievably, over the last 6 years, we've been turning away 30 to 40,000 nurses or people from becoming nurses each year. And these may be conservative estimates. The very people we'll need to replace this aging and soon-to-be retiring workforce. Why should we be concerned? 4 reasons. One, nurses seem to be the glue that holds the inpatient and outpatient in all settings of where healthcare are together. They're the glue that holds the systems together. Jobs are at risk. The AHA points out that within community hospitals alone, 5.2 million jobs, another 8.7 in industries that are related, closely linked to the healthcare sector. So if we have shortages of this size, we will be seeing reductions in capacity within the inpatient setting, shutdowns of outpatient settings, etc. These will have an impact on jobs. The third reason is health reform. How will we be able to ensure all these millions of Americans with an aging and shrinking RN workforce. It's just not clear that we have others that will be able to step in place, particularly as we're looking at shortages of primary care physicians as well. And finally, why we should worry is that we've seen over the past several years increasing evidence from a wide number of studies published in top journals showing that nurse staffing is associated, and I've just listed a partial list of the outcomes that we know of. And then policy has picked this up, where the National Quality Forum, the Joint Commission, the AHRQ Patient Safety Indicators, and CMS on their payment policies now are including nurse-sensitive quality indicators. Final slide is what to do. And the good news is that the ergonomic environment, which is so important for these older nurses, the private sector is making significant strides in trying to improve that environment, as well as attempt to make a more efficient use of nurses. So the private sector is responding. What I would like the leaders group to consider is recommending the funding of a study, thinking of something perhaps of an Institute of Medicine study that would objectively, clearly define and determine what are the underlying sources of why we're turning away so many nurses. Clearly objectify that, and then determine the least costly, the quickest options for both the private sector and the public sector on how we might resolve that capacity quickly. And then if we were to use public subsidies, I would like to suggest respectfully that those subsidies only be given to schools that agree to emphasize quality and safety in their curriculum. And then perhaps to give those schools even more money if they were to reach out, work with medical schools, schools of pharmacy, administrators, others, to have an interdisciplinary program of quality and safety. And finally, we need to target men and Hispanics for future nurses. I think it's highly unlikely that we will find all the young women that we will want and need for the future of the workforce. We're going to have to look at other sources. Thank you very much.
Thank you. Dr. Jacobson, you going to come up front? Okay.
Great. Good afternoon, and it's a pleasure to be a part of this forum. If you look at the difference in the per capita expenditure of for healthcare in the U.S. versus Europe, UK, and Canada, there is a significant gap of about $3,500 per person. If the healthcare outcomes are not much different in these populations, there's a difference, obviously, in the value of what is being purchased. A simple approach to looking at what is the reason behind this gap has three major buckets. One bucket is the price that we pay. Another is the overhead, unnecessary, and in some cases necessary overhead. And then there's a third bucket that I call volume and variability, and I'll address that in more detail. Just to give you an example, a partial list of each of these categories. Price includes the salaries of the healthcare workers, and of course in this country physicians by and large make significantly more incomes than they do in these other countries. Also the cost for prescription drugs and devices are more in this country than in others. And then of course embedded in the price that providers charge is the fact that they deliver uncompensated care. On the overhead side, actually there's some overhead that's built into the price, and that on the provider side is really the cost of billing and collection and compliance, the readiness factor, the cost of overcapacity, the cost of malpractice. On the non-provider side, the overhead is really largely around administrative costs within insurers in actually consummating the healthcare transaction. And where I'm going to spend most of my time, of course, is this issue around volume. And volume in the broadest sense means that we do things that we shouldn't do, and we don't do things that we should do. So it's both over volume and under volume. And there are three problems there. One of them is the lack of evidence-based decision making. The other is the variability in practice. And the third is overuse, misuse, and underuse of resources. Now, by and large, the discussion about the healthcare reform has had a preoccupation with paying. How much we pay is the price. How we pay or get paid is the friction around the healthcare transaction. And then The most important thing, though, that needs attention, and we're all talking about it already on the panel, and I see there's a lot of common ground here, is what do we pay for? And we need to pay for the right thing and only the right thing. And so we, I think, simply describe healthcare as an information-dependent service business. You have to have the right information available at the right time in the right setting to make the right decision. This is true throughout the continuum of care. It's true for screening, it's true for prevention, it's true for acute care, chronic care, rehabilitation, end-of-life care. Each one of those parts of the continuum have a knowledge base, and that knowledge base needs to be applied as perfectly as possible. So at Vanderbilt, we've been developing as much information technology tools as we can to support the delivery of the right care at the right time. And I want to just give you some real data. This happens to be the ventilator-associated pneumonia rates per 1,000 ventilator days at Vanderbilt. And we got around to having specific protocols that have supporting information technology as well as dashboards. This is largely, the success of this is largely due to nursing care. But you can see that once we implemented that already in this year, we've cut the ventilator-associated pneumonia rate in half, and it's going down rapidly. The same is true with bloodstream infection rates. We actually tackled that project a few years ago, and you can see that, again, with evidence-based guidelines, the right information technology, the right dashboards, people doing the right thing and only the right thing, you can really, really markedly reduce the cost, the complications, and obviously the quality and the value that you deliver in healthcare. Another example of providing value is actually, we now make available to all of our physicians who practice in the hospital data on what they're doing and how much they're spending with each kind of patient diagnosis. And the physician knows what they are doing, and the other physicians that are seeing similar patients are coded. And when you look at that, what you see is that there's tremendous variability. And you see that once the data is made available, the physicians begin to aggregate around the mean. And what we found actually is if you provide feedback to physicians, you can reduce the cost per discharge by 14%. That's a real reduction. Now the other thing, and Mark Frizzy is here, so maybe when we get into the discussion, if there's an issue around this, he can pipe in. But we, with the generous support of the state of Tennessee and ARC, developed the Regional Health Information Organization in Memphis, and we believe it's been a huge success. And the reason it's been a huge success is that we decided that interoperability was not the achievable or most important goal to reach first. We felt that actually crawling across any medical record and providing information to caregivers so that they can, when they're seeing patients, make the right decisions, gets them to deliver value. An example of the value here is if emergency rooms in the city of Memphis have access to information about what imaging studies patients have had, when they come to the emergency room, just the avoidance of unnecessary imaging saves millions of dollars a year just in one city. So the use of information technology in an appropriate way is really important. I will end with that.
Well, good afternoon. And, Senator Baker, Ms. Burke, it's an honor to be here, and it's also, I'd be remiss if I didn't acknowledge your two colleagues. Chris Jennings was a terrific influence from the White House when I first came to VA, and Mark McClellan, a remarkable, insightful, and brilliant colleague whom I counted on a great deal as we worked on improving the value of healthcare in VA. And that's really what I want to talk about today is the intersection of health information technology with value, one of the pillars that Dr. McClellan mentioned here in the outset. I would agree with you fully, Senator, that Americans can get the best health care, but I think until every American can get the opportunity for that excellence in health care, we've got a ways to go. And I know you believe that as well. It's been noted that we have a sick care, not a health care system, and that we have gaps in quality and safety. And so I think it's fair to say that our system has limitations that we need to address in concert. Gaps in safety, quality, and those, of course, for the resources expended, as Dr. Jacobson so eloquently stated, lead to gaps in value. And as healthcare moves from the traditional factories of healthcare, the hospital, to home and other environments, those information gaps become even more critical. And the incentives that are traditionally driven healthcare are related to volume, not quality, not value. The value that we require in healthcare will accelerate with health IT, because information, of course, is the currency of healthcare. It's also the currency of healthcare value. It's needed to make good, informed, and credible decisions. It's also necessary to be able to demonstrate value. And that need for demonstration will itself drive the implementation of health IT. The third point I'd make in my brief comments this afternoon is that health IT opens doors for information-age healthcare. It's the opportunity for personalized medicine, medicine that's tailored to us as individuals, and those advances in this health information technology also accelerate our competitiveness as a country and leading in biotechnology. So let me quickly share with you two transformational examples from VA. First, with a preface, the President's Information Technology Advisory Committee, Council, bipartisan group found themselves that 1 out of 5 lab tests needlessly repeated because previous records weren't available. 12% of orders not executed as written. 1 in 7 hospitalizations likely occurring because previous records were not available. Safety gaps, 98,000 patients a year dying unnecessarily. A quality gap, virtually every patient experiencing a gap between the best evidence and the care they actually get. And I'd say that adds up to a remarkable compassion gap. It's already been noted that perhaps as much as 1 out of 3 health dollars are lost to inefficiency, and I think Dr. Jacobson outlined that very well. Well, how does that relate to information? Let's go back to 1996 in VA and a patient in a paper-based world making an appointment. The appointment's scheduled, the unit clerk calls to request the medical records for the day of his appointment. His chart goes into a queue for delivery. New labs come in. Where do they go? No, not to the queue, to that file on the right, the loose filings, which are measured in feet, meters, yards, 100 yards, beyond. Patient might even be seen at another site, and those data, where do they go? Loose filings as well. Medical records might get pulled, the patient goes somewhere else. Where's his chart? Well, that's how 60% of healthcare operates today, and the points, again, that were made about the importance of health information technology in Western Tennessee are absolutely apropos. You can't get to high-value healthcare without information necessary to make a decision. In the early 90s, VA was not providing optimal care, though there were lots of caring people, and it was fairly brutalized in the media and public sense. VA had 2 problems. It didn't deliver quality for veterans. It didn't deliver value for taxpayers or to our board. And Senator Baker was a member of that board. It was called Congress. And so we looked at a number of buckets that we had to improve, and not just things that were sort of doctor-centric, nurse-centric, health system-centric quality, but is the care accessible, satisfying? Does it improve function, improve the health of a community? Is it cost-effective? Well, over the period of time, let me give you a report card, 10 years later, outperformed all those settings in 294 measures of quality, leading to the conclusion VA patients scored better on adjusted quality than patients elsewhere. By the way, at that same time, access to care went up 350% from 200 to 900 clinics, benchmark satisfaction, benchmark function, benchmarks in age-adjusted rates of amputation for diabetes, and incredible contributions to community health following the devastation of Katrina. Whether veterans relocated to Washington, D.C. or Washington State, they had immediate continuity of care. They could have prescriptions refilled because their electronic information followed them wherever they went. And oh, by the way, while your healthcare dollar and mine became a little less valuable, healthcare inflated 44% over that period of time in nominal dollars, about twice that adjusted, cost of care for veterans with measurably better quality, access, satisfaction, improved function, an electronic health record and continuity across environments went up 0.8% in nominal dollars. Over time, actually, it became less expensive. I think there's a lesson there, and we've categorized that when Matt was asking that I'd speak on the intersection of health IT and value. Here's an article that we'll make available that really outlines that relationship. Well, we're in an environment that's highly focused on value, and if someone dropped in and asked what have the traditional incentives been, they've been really volume-based. The more you do, the better you do. There is a value question here, the relation of quality to cost. And under Mark's leadership at CMS, that was really put front and center on the table. Value-based healthcare, the idea of purchasing care from providers who provide higher quality more efficiently. One permutation of that is pay for performance. And the value chain or the incentives there are also pretty obvious. The better you do, the better you do. Value-based insurance design or value-based purchasing is the concept of moving the business to those providers that provide better care more efficiently. The better you do, the better your access to patients and premium reimbursement, the better you do. Now, I hate to be so crass as making this purely financial, but as a patient and consumer, I really like this set of incentives. And as a healthcare provider, they don't intimidate me. In fact, in our environment at HCA, the use of information technologies allowed us over the last 18 months to go from about 12% of our hospitals, 170 hospitals, in the top 10% on CMS measures, to 88% in the top 25th percentile and 65% in the top 10 percentile on last quarter's current performance on the CMS measures. Also allowed us to address the issue of hospital-acquired infections. MRSA is one example. And cutting infections with the use of the convergence of information technology reduced surgical site infections by 46%, bloodstream infections by 1/3, ventilator-associated pneumonia by 2/3. And the great thing about this is that patients deserve the highest quality care of this sorts of safety. The people who pay for health care, the employers and the patients as consumers themselves, also should and deserve the ability not to pay for care that is less than optimal. So it's been really that convergence of health information technology that's allowed us to translate the best research into practice. But the opportunity for the future also is with the implementation of health records, translating practice into new information, better policy, new discovery, new opportunities for this country through the development of personalized healthcare and genetic technologies. Imagine, if you will, that these students' stained glass panels are two patients. On first glance, they look the same. Our colleague at Vanderbilt, Bill Stead, would tell us that the physician or clinician of any stripe can only manage 7 variables simultaneously. If you actually had a computer to ferret out those variables, you'd notice that there are a number of differences. Well, the ability to move from being lumpers to being splitters allows us to give each patient tailored health care and allows us to develop new tools that can make us an even greater economic powerhouse in the biotechnology. So let me close with these 4 predictions as we move from industrial to an information age. That information allows us to move from fragmented care where information is only available to inform decisions 60% of the time, to create continuity across sites that include the patient's home, even for very advanced care, and care is informed 100% of the time. We move from an environment where clinicians relied only on judgment and best recall to really being aided by computers for the best decision support, the best evidence. We move from a model of mass production, one size fits all, to a model of mass customization where patients get personalized health care. And with this information explosion, not only can we develop and deliver the quality that underpins value, but the relationship of quality and cost to value, and value itself becomes increasingly transparent. I want to thank the Bipartisan Policy Center for your terrific leadership. We have issues to address, but we also agree with you that there should be great enthusiasm for Americans' ability to really deliver the best care and to do so in the future even more consistently. Thanks.
Nancy?
Well, good afternoon, and thank you so much for the opportunity to be here today. I don't know about you all, but, I think I've had enough turkey. Have you had enough turkey? I mean, there's turkey salad, there's turkey surprise. There is roasted turkey, and there's fried turkeys now. But, I used to be addicted to turkey after Thanksgiving, but, thank goodness I quit cold turkey. So I just wanted to share that with you today. St. Thomas Health Services, I'm representing them. We have a 4-hospital system with numerous clinics and affiliated physicians. And we're comprised of the St. Thomas Hospital and Baptist Hospital in Nashville, Tennessee, of course, and then the Middle Tennessee Medical Center in Murfreesboro and the Hickman Community Hospital in Centerville, Tennessee. I've been asked today to talk about the rural health perspective, about our Centerville Clinic and our Lyles Clinic, and our Hickman Community Hospital. In Hickman County, there's over 23,000 people, but we're one of the largest counties in the state of Tennessee. Hickman County is 87th% per capita in regards to low-income families and 60th overall in the state for those living in poverty. You know, historically, Hickman County has had the highest suicide rate in the state. Alcoholism, tobacco use, and depression rates are high. Teenage obesity and teen pregnancy are very high as well. You know, barriers to care in rural Tennessee, we have lack of physicians, lack of nurse practitioners, lack of mid-level providers. We have poverty, and we have transportation issues. Our Centerville Clinic saw nearly 19,000 patient encounters last fiscal year. Our Lyles Clinic saw over 3,200 patient encounters. We have 2 family practice physicians in Centerville, 1 geriatric specialist physician, and 1 nurse practitioner. At the Lyles Clinic, we have 1 family nurse practitioner. Our clinics provide primary care. We also have access to social work, counseling, suicide prevention, lifestyle intervention classes, focusing on prevention of diabetes, hypertension, cardiovascular disease, and obesity. The hospital and our clinics are Joint Commission accredited. You know, we have some specialists who will come to Hickman County, cardiologists, ophthalmology, and orthopedics, but many have to travel long distances for specialty care when they live in rural areas. There's not enough specialty care in the rural area, but we have an integrated health system which will see patients from rural Tennessee, from Hickman County, who are affiliated with our St. Thomas Health Services physicians and will receive hospital care as well. The number one challenges of rural health care seem to be recruitment and retention of physicians and mid-level providers, healthcare providers of all types, lab technicians, nurses, physical therapists, rad techs, specialty care. Patients come in very ill. They come in when, you know, there's almost no other place to go. Patient, a 40-year-old lady came in the other day, several months ago, complaining of colon problems. Well, it was decided she needed a colonoscopy. She had colon cancer. By that time, we found that it had gone to the breast and to the bone. This 40-year-old woman left 3 teenagers and died 4 months later. What can policymakers do? I think we can listen to our healthcare providers. I think that we can hear what healthcare providers have to say of what works and what does not work. And as a practicing nurse practitioner, I can tell you we don't need more paperwork and we don't need more hoops to jump through. We need a continuum care for our patients. We need access and we need coverage. I also represent Ascension Health, which is the largest nonprofit health system in the United States. And we have 6 guiding features for a reformed healthcare policy. We're advocating for 100% access, healthcare that leaves no one behind. 100% coverage, that there's destination clarity and coverage for all. We hope for insurance benefit package that's equitable to most plans in the community. We would like attention to mission critical populations, those who are vulnerable, those who live in rural areas and have access to care issues. Insurance reforms and economic viability, public-private partnerships, public dollars reimagined. Will this health care plan be there tomorrow and for everyone? And I've heard the word possible today, and we believe that is possible. And thank you very much.
Nancy, thank you for your comments. And we have a little bit of time for discussion on this panel. As I said before, we want to build on it in the second panel as well. And maybe Sheila, if you don't mind, I could start with you.
We've had a remarkable array of comments, and I think enormously helpful to our efforts. But I wanted to start, if I could, with Dr. Jacobson and Dr. Perlin, and I'm particularly struck by both of your comments regarding the importance of informatics, both in the ability to guide the kind of practice that's occurring, in essentially the feedback of information to your physicians, the particular value you've gotten for that, in terms of the change in behavior. One of the challenges that we've faced in trying to assist the leaders in looking at these issues is the upfront investment for the long-term return. and the challenge that one faces congressionally when you're promised the long-term value of something with an immediate upfront cost. I wonder in both the cases of the VA, but also here at Vanderbilt, the amount of time that occurred between the investment in the technology and the IT and when you began to see a return in terms of a change in behavior. I'm also quite interested in the kind of pushback you got from the physicians and others in the hospital as you began to implement those changes, particularly with respect to the VA, the question of how quickly did you begin to see the return, what kinds of investments did you make in the training of physicians and others in the use of that information, and what barriers did you confront in putting those systems in place? Again, as we look at trying to suggest to the leaders the kinds of investments to be made, we want to understand what has worked, what has failed to work, and what kinds of systems made the most difference.
I'm glad you asked both of us the question. Not only do we agree on many things, but we happen to be next door neighbors. Vanderbilt, of course, has done most of their information technology tools through homegrown development. We invested in the mid-'90s, early to mid-'90s, in developing a medical informatics department and have 50 faculty members and a PhD training program. And so we actually used our healthcare system, initially the hospital, but now the outpatient setting, as a living laboratory to develop applications that will actually fit into workflow and will lower the barrier to adoption by users. So the best thought out ideas of what might work, actually when you put them in action in the real setting, don't work. And so what we were able to do was to, through an iterative process, develop applications that really gave us a value for the investment. And the two key ones that give us the greatest return are the access to the patient's medical record through our electronic medical record approach, and the other is evidence-based decision support with order sets. And I think those two are the essential things that that any healthcare system needs to have, and especially if they can have it both in the inpatient setting as well as connected to the outpatient setting. Whenever we turned on a new application, we actually got the return on investment immediately. So within the first year, usually we already get close to paying what the cost of producing and implementing the application. And those returns come from a number of different ways. One, of course, is that you do reduce the workforce in many cases that have to do things. Can you imagine how many people it takes to lug around those charts that Jonathan showed on his slide? That goes away when it happens electronically. And the second thing is you begin to control resource utilization and standardize the use of resources. And when you do that, and you get paid a fixed rate for what you deliver in a DRG-based environment, you get that return on investment right away. And I'm actually amazed at how reluctant hospitals and healthcare systems are in accepting the value proposition of at least those two applications. And they don't have to be that expensive. The return is quick, and it's a great return.
Well, thank you, neighbor. You asked really three questions. What is the payback period for the return on the health IT? How did we deal with physician engagement and that come in both environments, VA and HCA? And how does that extrapolate more broadly? Well, first, in VA, I think it was really about a 7-year period where it was very clear that greater efficiencies were introduced. And this is a little bit of inside baseball, but the Washington policy challenge is this is something that is not going to offer a positive ROI if scored for a 1-year return. And I think we have to look at this as a longer-term investment to really deliver some of the efficiencies. But as I think those slides show, it underpins the ability to create continuity across environments, the ability to allow care to be delivered in non-traditional environments successfully with fewer of the handoff mishaps that Dean Conway-Welch alluded to. The question you asked about clinician engagement is absolutely critical. It has to work for clinicians. It has to be a system that's friendly. Now, there is literature that suggests that there is a relationship to the age of physicians, with some of the younger physicians taking to the computers more efficiently. I will tell you that in VA it was a U-shaped curve, and I'm proud to note that some of the more senior clinicians were among the earliest adopters. But more broadly, there is an expectation, particularly among the newly minted clinicians, new nurses, pharmacists, physicians, who've grown up with computer, have gone to school with computers, have rented houses and apartments by computer, bank on computer, probably dated by computer, and find themselves in healthcare with a pencil or a pen and paper, and are really not equipped with the right tools. The sorts of tools that Dr. Jacobson alluded to are the ones that I would agree with. The standardized order sets that connect the patient's condition with the right intervention. In fact, not only the thing that the evidence says is the best, but the thing that is actually most efficient in terms of improving that care. The ability to have the patient's information there. It's kind of ironic that I can take my dog, who has an implantable chip, to any vet in the country, and they can read my dog's history. I can take my car to any Jiffy Lube in the country, and they can read my car's history. But I challenge any of us to walk into most healthcare environments and find our history from any other source than a clipboard that we've filled out. We need to do better in this. So there's an efficiency there. And that gets to the third. In the VA, there was an advantage. The payer and provider were one and the same, and so the efficiencies accrued to everyone. I completely agree with Dr. Jacobson that there are efficiencies that accrue to the providers alone, but I think we need to make the incentives more clear-cut. I'm very proud of the work that Mark helped to lead with the AHIC successor that Brookings has been so much a part of, because that puts one of the features into place, and that's the standards. The standards allow for vendors to invest in making systems that are compatible and interoperable. It allows those systems to be certified, which reduces the risk to purchasers of systems like physician practices, like hospitals, like nursing homes, like home care, et cetera, from buying something that's obsolete and not compatible. So that puts the standards into place. I think we have a little bit of work to do in terms of that final piece, and that's aligning the incentives. Thanks.
Thanks, Jonathan. Chris, did you have a comment to add?
Well, this is for actually the whole panel to discuss, and I would like just to build on that. I guess I would say that most hospitals, I don't think, have completely embraced it as the value proposition. I'd like you to maybe explain exactly some of the reasons why. I think, Dr. Perlin, you've just laid out some, but we frequently talk to people about the issue of value and quality and how we have to realign and et cetera. And we have all the providers saying medical homes and enhanced quality, and let's figure out how best to do this. But I'd like to ask you all where you think the primary objections will be coming from, what you think the primary barriers are, and how do we, more importantly, overcome them as we try to make some recommendations and options for the leaders to consider as we go forward.
I guess since I got to go first last time, I get to go first again. In the concept of the patient-centered medical home and talking about barriers, the main thing we're doing is we're trying to do 4 things at once as it relates to the patient-centered medical home. And really, the healthcare, I don't want to really say reform, because reform, all you do is tinker with something that's almost good. We're talking about trying to transform, truly change everything the way we do. And the whole concept about the patient-centered medical home is defining it, because you're right, we're not really sure exactly what it is and what it's going to do. And some of the barriers is just moving away from what we're doing already. I think it's very appropriate that you got Dr. Welch and myself sitting beside each other, because usually we're sitting across the table and having discussions. And I think the first barrier we're going to have to move away from is the either or, and start focusing on and talking about the team and how the team's going to work in way of providing the health care. We have great physicians in this country, but if you remember back in the Olympics, we had some great sprinters in the Olympics. But in the relay race, we lost both of them and didn't even get to place because they dropped the baton. We've got to work on ways of being able to communicate, getting the healthcare industry so that we can communicate back and forth, whether we're dealing with vendors that sell our products, whether we're dealing with the people that set the rules that keep us from being able to communicate with each other, and then our willingness as a group of healthcare providers to come together as a team and say, we're going to take care of this patient or this community as a team instead of as individuals, and quit worrying about ourselves as individuals as much as we're worrying about what we can do together. And I think that's going to be a major barrier that we're going to have to overcome.
when the term medical home is used, people almost by definition assume that a physician is home. And that's not always the case, particularly for poor patients, underserved patients, uninsured patients. They frequently never see a physician. They generally see a nurse practitioner in the community health clinics and the federally FQHCs, which run on the backs of nurse practitioners. So I would really concur with Dr. King that being able to get the right patient at the right time, seen by the right provider for the right reason, for the right amount of money, is really the goal that we have to work toward. The expectation that a physician will always be available to be home in the medical home, I think, is a huge barrier.
Colleen, I wonder if I could go back to a comment that both you and Peter raised about the shortage of nurses. I mean, that's an issue we face for a number of years. But Peter, you mentioned essentially, both of you did, both the number of nurses or the number of individuals who were applying to nursing school who got turned away. Colleen, you suggested an investment in education in terms of educators. Peter, you suggested a study to look at why it is that people were being turned away. I'm trying to understand, even best guess, what you imagine. Is it a question of slots? Is it a question of an inadequacy of the number of programs to train? Is it, I mean, I'm trying to understand the connect between those 2 points.
The easy answer is that there aren't enough faculty and that there aren't enough clinical placements.
Okay.
That's the easy answer. I would suggest that an underinvestment in technology, both in the technology, the hardware of teaching, but also teaching teachers, nurse faculty, how to use technology, is a more complicated answer to that question. At Vanderbilt, we have almost 700 students. 350 of them, or a little less, are actually on campus. The rest are all over the world. We have several students who are in Iraq, and they're getting their masters online. We have several in Hong Kong. So that has allowed us to move away from the bricks and mortar and invest in our faculty to teach smarter and therefore be able to broaden the number of students that we have.
I'd like to thank all of you for your contributions to the panel. It's very clear that there is a better vision and some clear implementation of how to deliver care that gets the handovers right, as Colleen said, that emphasizes prevention and coordination of care, doing things technically well, as well to get the right care to the right patient at the right time, to do it as a team, to achieve transformative care through health IT and protocols on what works and some of the other steps that you all have talked about, and then backing that up with measuring what is going on and what actually works, and then moving our payments, our benefits to support that more clearly. So some very strong ideas here, and I really want to thank you all for the contributions. And I'd like to turn now back to Senator Baker and thank him for bringing us all together and for his leadership for this effort. He has to catch a plane very quickly, and we're going to continue. We're going to continue this effort with him in the coming weeks to really follow through on some of the ideas that you all have talked about, and we're going to come back to it in the next panel as well. But I just wanted to close out this one by seeing if Senator Baker had any final comments.
Thank you very much. I must say I came prepared to see that and to hear excellent presentations, and I have not been disappointed. But I have concluded that there are two classes of answer. The first is what I call the efficiency answer. We can improve this system perhaps, and many of you around this table have done that, to our benefit. At the same time, you incur, it seems to me, a danger. You incur the danger that you mechanize the practice, that you defer to a standard pattern instead of the subjective judgment of a good practitioner. I have no answer for that. I simply say that computers are not the whole show, and that given a choice between a good computer and a good doctor that I have confidence in, I would pick both. And I think that's where we'll end up. But I think I'm leaving this, and I regret that I have to leave, but I think I'm leaving this with the view that the effort is worthwhile. This encounter this afternoon is worthwhile. You have not produced any answers that I'm aware of, but you have done something else. You've cross-pollinated your ideas. You've shared them with the people who are best in a position to deal with them. In my own case, you've reinforced my conviction that there are no easy answers, and that Congress, of all places, is ill-equipped to try to deal with it. But we have to. It's in the nature of the system. And therefore, the system must depend on you to advise, suggest, and to guide them in the right direction. That may sound messy, it is. It may sound inefficient, and it is. But my friends, it's the best system in the world. I'll conclude with one, I guess, over-philosophical view that I believe is my own. I think the real greatness of our country and our system is our ability to harness, to collect, and understand the collective wisdom, indeed the genius of the American people to address an issue and to provide an answer. I think you're well on the way. I'm proud to be part of it. I congratulate all of you for being here. Thank you.
Thank you all very much. Now, we're going to take about a 10-minute break and then reassemble for the second panel. Thank you all.